Good morning, everyone. Thank you all for coming. I was afraid there'd be like no one in our session because the other session is so popular. But this morning we are going to talk about the health impacts of climate change and environmental justices on vulnerable populations. And I think Dr. Bullard gave us a great intro to that, talking about what's going on, why this is an issue. And so if we're talking about health and community health, I think the world is starting to recognize, or people are starting to recognize, that health is a huge part of that. It's not, when I used to talk to people about climate change, particularly Black people maybe 10 or 15 years ago, they would say to me that that's a rich white person's problem. And so I've been kind of pounding this drum for years, telling folks, we are at the tip of the spear. And as Dr. Bullard explained, the folks who kind of contribute the least to the problem are impacted the most. And so climate change is something. Well, now I'm so glad that we're kind of marrying the two, climate and environmental justice, because we can talk about climate justice and people were thinking they were two separate things. They're not two separate things. And here we are, so influenced and under the gun health-wise too. I think it's really important to talk about that because people often, when you talk about climate change, they think that's something like their grandchildren may have to deal with, and so we can put it off. But when we talk to them and show them the health impact that it has right now, you know, who has asthma, who gets the worst, like drinking water and get displaced by sea level rise, those kind of things. Those things are happening right now. And to certain communities, way more than others because of things like redlining and historical injustices. So today we have 4 great panelists to speak about these issues and more specifics. And I think a lot of their work is targeted in like the Charlotte area in North Carolina, but that's just kind of a template for what's happening to communities like ours all across the country. So I wanted to start off with former Mayor Jennifer Roberts, and she's also founder of the Charlotte Mecklenburg Climate Leaders and has a whole bunch of great credentials, and I'll let her tell you all about that, but it's important that we see the political aspects of this because so much of this is driven by the politics. Who cares for what's happening to our community? And when we were saying, what's happening? Why isn't this a bigger issue? And I think it's because the people don't understand, a lot of the people don't understand how this is affecting us personally. And when they're convinced that we have to have these, you know, we need jobs, so we can't push out this polluting industry because we need jobs. And I always say, folks in Myers Park have jobs, and they don't have to live with, you know, hog pollution and things like that. So when folks understand that we are entitled to a clean environment as much as anyone, and how we have to fight for that and make that a voting issue, a marching issue, that's when we will start to make progress or continue to make progress. So first, Mayor Roberts, thank you.
Anyway, I'm just really pleased to see folks here. I'm so pleased to see Wake Forest and Atrium working together on faith, health, and the environment. One of the big things that before I was mayor, I was also on the county commission, and one of my biggest struggles with the way that our governments work in North Carolina is that our cities are the ones that do infrastructure, roads and police and zoning, and our counties are the ones that do public health. And they have different budgets, and they don't always talk together or play together well. And so what we see is decisions made for infrastructure that don't take into account the public health aspects of what we're doing. That's where we all come in. That's where the public and advocacy comes in. I'm going to talk about that in just a minute. Okay, it's not advancing. Wait a minute. Oh, down there? That worked. That worked. I got it. Oh, now we're going to one. There, okay. So Dr. Bullard talked a little bit about all the different ways that health is impacted by climate change, vector-borne water, food safety, mental health is one thing that we didn't talk about. And a lot of times when I give this talk, I have a slide of firefighters kneeling by a house where they found someone who drowned inside their house. And they kneel in prayer because it's really hard when you're an emergency responder to find dead bodies. And that's all part of the mental health and the trauma that kids see when their houses get washed away. That lives with them. So mental health is something that's connected. And I want to talk quickly about the vector-borne diseases because we have a tick problem and a mosquito problem in North Carolina. And we had a U.S. Senator die from a tick bite, Kay Hagan. And we know Lyme disease, Rocky Mountain spotted fever, so many things. And there are more and more ticks. I know I went for a hike in New Hampshire with, my family has friends up there. 9 ticks on my body when I got done with the hike. Luckily, none of them had embedded yet. Anyway, I don't want to freak people out, but but these are all issues related to climate change. As the weather warms and as our climate warms, these are all going to be bigger and bigger health concerns. And again, Dr. Bullard mentioned some of these, the energy burden, vulnerable industries. I want to talk real quick about the vulnerable industries here in Charlotte. We had an airport worker die from heat exhaustion a few years back. Some of you may remember, and the airport workers came and the union came to, of course, we don't have unions in North Carolina, but they don't have bargaining power, but they are organized. They came and talked to the city council about, can you require breaks from the heat, water, certain things for people on the tarmac, because those little machines they drive around are not air conditioned, and that tarmac gets really hot. Anyway, one more vulnerable industry we know most folks who are working in baggage claim, et cetera, are people of color. Minority ownership, property values, we talked a little bit about that, about if you've been in a red line district, your property value is not increasing, you're more prone to flood, you don't have that wealth accumulation possibility. And then insurance costs, we talked about that as well. I love maps, and this is just an example. That's Mecklenburg County in the middle and the right. That's Charlotte with redlining from 1935. You can see the pattern in poverty, and where in the middle map, the crescent, we all know the crescent here in Charlotte, the east and west, it kind of goes around that wedge. In the middle of the Myers Park, Eastover, tree-lined streets and bigger properties, more greenery, green infrastructure, slower, no interstates. The interstates follow the dark area of poverty because the interstates went through black and brown communities. And that's where the air pollution is centered. And one of the ways, and on the right, the lighter areas are the more polluted areas, but you can see how it directly stems from the red line that happened, and that's where the interstates went. One local example that really illustrated this for me in terms of air quality, during COVID, I'm part of a group called the Reimagining America Project looking at racial justice, and we have a pastor who is with a church in Hidden Valley. And we did Zooms during COVID, but he was frequently absent because of all the funerals that he was officiating during COVID. Black and brown communities lost more people to COVID because of their compromised respiratory systems. And that was a very specific example. Again, the faith aspect. This is apparently one of my colleagues going to use this slide as well, but the CDC, and I got these before the current administration, so we think this is good information still. Just saying. So this shows concentrations of chronic illnesses. Again, we see the crescent. And we know our rates of asthma can be 4 to 5 times as high in that crescent area as it is in Myers Park. We know that heart disease can be 4 to 5 times as high. And I also looked at high blood pressure and diabetes. And we know that these have, they're connected to the environment. We also know that the historic redlining, where the air pollution is. One more thing that I often mention is that you think about chronic illness and people exposure to toxins. So before 1972, the Clean Water and Clean Air Acts, black children were swimming in the creeks because they didn't have access to the white swimming pools. We didn't have nice swimming pools in black and brown neighborhoods. They swam in the creek. And before 1972, they were swimming in pollution. They were swimming in sanitation, the sewage from places along the creek that emptied into that. So that's where chronic illnesses start. So I'm going to talk a little bit about policy response and some of the things the city of Charlotte has done and noted, even though they don't do public health. They look at business opportunity, they look at job growth, all that economic stuff. And they have designated corridors of opportunity, which resemble the crescent. So you can see the Beatty'sford Road, east and west, Wilkinson, Sugar Creek, and they're trying to support small businesses. They're trying to direct infrastructure improvements. We've seen that at 5 Points and some of the things that have happened right near Johnson C. Smith. We saw that with a streetcar going to Johnson C. Smith and going beyond. So they are trying. One of the initiatives is the historic West End Green District. They are planting more trees in the area. They know that that's a tree desert. Electric vehicle, this is a picture of the Governor Cooper came down for the installation of a charging station. Of course, as I was walking back from this gathering, somebody stopped me and said, what are all those people doing over there? I said, well, this is an EV charging station. She goes, who in this neighborhood can afford an EV? and she was kind of angry. And we get it. But this is building for the future. And there's also some training and education and advocacy going on with that. And Clean Air and Sea has been a big part of that as well. And there are a lot of community groups that are helping with this. Maybe we can talk more about that. We also know that in low-income neighborhoods, people don't necessarily want trees in their yard because they can't afford to maintain them. I remember walking neighborhoods when I was running for office and seeing limbs on roofs that had been there for years because they didn't have the money to hire some crane to get it off their roof, and it didn't cause a leak. It was just dented, whatever. So we know that kind of maintenance costs money. The city actually got a federal grant, again, this was a couple years back, to help maintain trees on private land, not just city trees in the median, but on private land, so they could actually help people in low-income neighborhoods maintain their own trees. And again, that green infrastructure is so, so important. You heard about the air conditioning, which is a big issue, and Action NC and Clean Air NC and a lot of nonprofits got together and found out that over 7,000 apartments in Charlotte don't have air conditioning. So, and you'll hear more about this, working on trying to get some kind of ordinance updated to require that. We know that, again, those are low-income neighborhoods. The slide on the left is a picture of the green roofs in Chicago. I just think it's really cool because what it shows is how hot a black roof can get. That's 151 degrees on the surface on the right. On the left, it's 72 degrees. And that's the difference that green infrastructure can make. And that is one of the things, heat kills, and it's that hidden thing. It's like the frog in the boiling water. We don't think about it. We grew up in the South, right? I grew up in that briar patch. Well, it is getting worse and worse. Our summers are getting hotter, and it continues to be a threat. So some of the policy things, again, zoning. We recently had an update to our 2040 plan, and the whole walkable neighborhoods is a goal, a 15-minute neighborhood where you can walk to your amenities. We've had some street diets. That's East Boulevard, and you can see that used to be a 4-lane road without a median, without trees. And I remember this going on because people were really upset because, it takes construction and traffic. And They were like, why are you getting rid of a lane? You know, we're going to have more traffic. Well, what you see is more walking and more biking, and the bike lane is protected, and you see there's a nice bus on there. Our bus infrastructure needs some help, but we can talk about that some more too. But anyway, these are the kind of things that the city is trying to do. They do have a goal to have their light-duty vehicles 100% EVs by 2035, and their heavy-duty by 2050. Again, active transportation is a big goal. They're supporting community gardens, again, green infrastructure. I found this article in the New York Times about, this might have been, I think it's a neighborhood in New York, but what they saw is when you put in green infrastructure and you have community gardens, you build community and you actually reduce violence. And you know, this is just one of the many ways that you can solve several issues at once by just supporting areas for green infrastructure and community gardens. And again, the challenge here is that our county is the one that does park and recreation, and the city is the one that does zoning. And so, you know, again, we have to get people to talk together. And our state government, you all know, is really the ultimate authority, and so they can actually overrule a local ordinance. And so what we found, we had on the county level, we had a setback for our drinking water. Mountain Island Lake is where we get our drinking water from. We had a 30-foot setback, and we required different things. And the state came back and said, you can't have a local rule that is more strict than the state rule. And you know, Mecklenburg County is very unique in the way that we have our density, our growth, the way that we are structured, and we have some needs that rural counties don't have. Unfortunately, rural counties are the majority in the legislature, and so we often are finding ourselves butting heads with trying to get ordinances passed at the state level. Now, one thing I didn't mention is that's me hugging a tree. It feels really good. You should try it. The county put these signs up and said need relief, hug a tree. But one thing I didn't mention, and that is that local advocacy has been essential to helping get change with our state and our local governments. When we saw the Strategic Energy Action Plan, which was passed in 2018, I initiated as mayor, but it passed the year after I left the mayor's office. But we had local advocates pushing. I attended, as the former mayor, I attended every committee meeting of the Environment Committee and actually texted people during the committee meetings to say, ask this, do this. And I remember this. And we got that to pass unanimously for the city to have clean energy goals. And there are actually solar panels on our city government building. You can't see them because, you know, but you can see them if you go to the top floor. You can see them over the meeting chamber. And they actually are building 2 major utility scale solar in surrounding counties. The city of Charlotte's actually paying to build it in another county to help reduce their energy and their carbon footprint. And that was because of public pressure, of people coming. And there's a great picture. June Blotnick in the audience was a co-founder of the Charlotte-Mecklenburg Climate Leaders with me. June, raise your hand. Yay. There's a great picture of June at the podium when they passed the Strategic Energy Action Plan, and a sea of green signs behind her saying clean energy, you know, environment, et cetera. And we know, because of those justice issues we all mentioned, that is going to help as we get more EVs out there. It's going to help the air quality in all those impacted neighborhoods that have been, you know, formerly redlined and don't have the same infrastructure. So if there's anything, you know, we can talk about this in the questions and answers, but local advocacy, showing up at meetings, calling and emailing, it does make a difference. It absolutely can change the way policy happens. I've seen it a number of times. And environmental justice, I still remember we started building out greenways when I was on the county commission, and of course greenways filter the water, the riparian buffers, they help with air quality, they do all these great stuff, active transportation, bikes and such. And I remember one of the county commissioners at that time I asked her about, well, what, the environmental justice. She goes, what's environmental justice? I mean, and this was only, 10 years ago. People still don't know. EDF has done a study, about 2/3 of Americans have never heard the term. And so working with nonprofits, working in the community, working with advocacy can make a huge difference to that decision-making that happens on the state and local level. We won't talk about federal right now. Anyway, look forward to questions and answers, and I'll pass it on to my next presenter. And Melba, you can do the next thing. Oh, and I think I just got out of the slides.
Okay, let's see if we can get back in
I
there.
talked too long and didn't push
Yeah.
the.
I hope we don't have. Oh, Sean's got to log us in. Yeah, he's outside and stuff like that.
All right.
Okay, could you?
Sorry, I messed up.
No problem. Can you ask Sean? Can you ask Sean to come in and get the computer? Oh, he just went. Okay, thank you. Okay. Well, while we are waiting on Sean to come and get our screen back up, I really want to thank the mayor, former mayor, for coming in and talking and giving us a kind of a political landscape of how this works. And our next guest, Dr. Aaron Levy will talk about he's a doctor, he's a professor, works with children and a hospitalist, and so he sees the impact day to day in his work. And I am I'm a journalist. That's kind of my profession and how I got tangled up with the Environmental Justice Initiative at Wake Forest. And one of the things the reason I got kind of focused completely on environment, almost exclusively, I'm a health science and environmental reporter. But during the pandemic, I had a grant from the Pulitzer Center to talk about the impact of COVID on Charlotte's Black community, because we do in North Carolina really great mapping by race and ethnicity, coming from like the civil rights. That was a mandate from the civil rights legislation in the 60s. And what I found was so shocking to me, because the people who were the most impacted by COVID, who suffered the worst, were people in our communities, were Black people. And it was because of where we lived, where the traffic went. And it was, I think I knew this, but seeing it right there and talking to the folks who were suffering just kind of unnerved me, and I put, that's kind of has been my focus. So I've interviewed a lot of people in this room, and it's great to see them in person. But I want to introduce Dr. Levy so he can explain about his work and show us how this plays out and how this manifests itself in day-to-day health of our community.
Thank you. Good morning, everybody. And thank you, Melba, Ms. Newsome. Melba. I'm grateful to be here today with you, and I'm really grateful to have also been privileged to listen to Dr. Bullard speak when I was about a decade ago, when I was first even just learning about environmental justice. That was an unfamiliar term with me as well. As I was researching and wanting to learn more, I think Dr. Bullard, you were the first thing to pop up on YouTube. And so you stuck in my mind, and when I found out that you were speaking today, I actually got really excited, and boy, did you deliver. And I feel even more motivated to do the work that we're doing here at Wake Forest, so thank you. So just a quick bit about me. I'm a pediatric hospitalist over at Levy Children's, just had a shift last night. And a lot of my work now is here with Wake Forest University School of Medicine, educating young students who are going to be our healthcare leaders of the future. I'm also a board member for Clean Air NC, and that's actually how I got introduced to environmental health. And June Blockman gets a shout out again. She was the one that kind of introduced me as I went through my pediatric training. And I just got more and more interested in it through my early career, and really wanted to make sure that other students and other trainees and future doctors, future nurses, future people within the community, we used education as power. In a time of misinformation, education from our most trusted people, whether it be our community leaders, our faith leaders, our trusted physicians, our family, that is where we really are going to draw our power locally. And so I guess my most important job is that I'm a dad. So that's my daughter, Josie. And this is her favorite book, or was it her favorite book? It changes every day. But she loves learning about how the body kind of works together, how the heart works together with the lungs, how the bones and the muscles have to work together, how our brain controls all those things. And it's really important to think about those interconnections. And so our students are in the other part of the building right now learning about how those body parts work together to function. But often what is left out in our education is how our body interacts with the environment around us. As we learn that the environment is not just out there in the woods, right? It's in here. It's where we came from this morning and slept last night, where we go to work every day. And so welcome to your first day of medical school. Since we are here, I feel it's fitting to just have a little case presentation like we do in class. So we have here, and this is actually a pretty common situation that we see in the hospital every day. So a 6-year-old girl with asthma, she presents to the emergency department with cough, wheezing, and trouble breathing. She was born premature, and she's been admitted multiple times this year already, despite being on medications for asthma and following up with her physicians and following all the instructions that we have given her as doctor. She lives with her mother and father in the historic West End neighborhood of Charlotte. And so I bring up that case, and we'll kind of come back around to it. But my daughter, coming back to her, said she wants to be when asked what she wants to be when she grows up, she says, I want to be an artist scientist. Artist scientist, what is that? And I realized a famous artist scientist said the following quote, realize that everything connects to everything else.
Yes.
Leonardo da Vinci said that. And he knew that centuries ago, right? We are interconnected. We have an upside down tree, which is actually anybody know what that is? Lungs, right? That interacts with the environment around us. We breathe in oxygen and expel carbon dioxide, and then the trees and the plants around us take in carbon dioxide for photosynthesis and expel oxygen. We have a reciprocal symbiotic relationship with them that is so important, just as important as our breathing. And so it's interesting that during my training and during all our students' training, I think smoking doesn't get ignored. The health impacts of smoking is well known among the entire community. But if I asked you, why don't you smoke? Why shouldn't we smoke? Why is it bad for you? We could get some pretty quick responses, right? But we don't talk about that in the same way that we talk about just the air we breathe every day, how that's a risk factor for your health, how it causes premature death, how it causes lung disease and cancer and worsens asthma and chronic obstructive pulmonary disease and other illnesses. It does not spare one organ in our body. And so it's connecting the dots, Dr. Bullard, it's a misconnection of the dots that we have to ameliorate, we have to amend. And so I want to ask you, how many breaths do we take in a day? Does anybody know, approximately, estimate? Ballpark? Anybody want to just take a stab at it? 10,000, not bad. 6,000? It's 20,000 breaths. And if you're a child who breathes faster naturally, it's 40,000 plus breaths in a day. So what if you're a person living in an area where you are taking every one of those breaths in a more toxic or polluted area than the person who's taking it in clean air? 40,000 times for a vulnerable child. And that's one day. So when we think about it that way, we're like, oh, it's just breathing, we're just going around, we're living in our environment. That is why it's a justice issue. And that is why we have to think about this from multiple lenses and why we need a sociologist to help us out. But we have to teach this to our physicians so that they are knowledgeable to help best take care of the patients in front of them. And this is already mentioned previously, but just to remind ourselves that we talk about social determinants of health and structural determinants of health. The environmental determinants of health are conditions in the environment where we are born, grow, live, learn, work, pray, and play, right? And so I think that this video actually, and hopefully we'll get it to work here, does a better job explaining the local impacts of this than I can. So I want to see if we can hopefully get technology to work for us. And if not, we can always try again later. I don't know if we're going to have success here. Let's see.
Let's try.
See if it may not be connecting. That's all right if we need to come back later. That's okay. Okay, that's all right.
What was that? No.
Yeah.
Play.
Oh. Let's see if we can get it to do that. That's all right. That's okay. Well, this was a video actually from Clean Air NC that actually talked about the local impacts. Some of it's already been mentioned, but I'll hit upon it later and see if we can even get the video working later if possible. But ultimately, the maps have been a highlight, I know, and I just want to highlight a few more areas that kind of align with the redlining in Charlotte. So a little bit more map time. So permitted air pollution sites. I used to serve on the Mecklenburg Air Quality Commission, and this is where we would approve permitted air pollution sites. And you can see where those highest pollution sites were built in Charlotte. In the redlined areas that were considered hazardous and had the cheapest property value, and so that's where they built the most hazardous pollution sites. Proximity to traffic, where the Interstate 77 and 277 have been built around, also has the highest density of traffic. And not only do we talk about air pollution and disruption to neighborhoods, as you can see in the Genesis Park neighborhood here, but also heat trapping asphalt from urban heat islands that have fewer trees, more traffic, and industrial pollution. And we already talked a little bit about it, but what does that mean for a world that's already warming over the decades, and what we're predicted to see over the decades, especially here in the South? Ooh. Says battery is running low, just FYI for our tech friends. So looking at the map and looking at some research and looking what across cities we see with redlining, that differences in heat, is that you can see a difference in the redline neighborhoods from the highest rated neighborhoods per the map, and you can see the differences in temperature across those neighborhoods. Over 10 degrees in some areas that were studied. And so this is a huge difference. If we talk about you having a 95-degree day and you have underlying health conditions versus an 85-degree, and then on top of that, you don't have the tree canopy to shade you, it actually impacts health, sends people to the emergency department, and is a big issue for vulnerable populations. And there's that tree canopy that we were just talking about. It's actually a reverse map. The darkest, most dense tree canopy areas are actually in the South Charlotte area. This was touched upon a little bit, but maternal fetal health, the area where one of our most vulnerable populations that I see, who, when you're born premature, it comes with other issues related to that, from chronic lung disease to developmental issues to issues just generally with your breathing and organ development. Those very children that are born prematurely have later issues later in life. And heat and air pollution, particulate matter, whether it be from wildfire smoke or just industrial pollution, actually contributes to premature labor and low birth weight. And so, again, those connections between the environment and our most vulnerable patients' health. And looking back at at our favorite maps again, let's go back over it. You can see where children that are born at the lowest birth weight live, and those same crescent communities that are impacted. Multifactorial issues, though, that lean back to historical redlining as part of the problem. And then asthma that was already touched upon, you can see the differences in the rates of asthma. So the disparities that had already been briefly talked about, that Black Americans are not only more likely to have asthma, but even more likely to visit the emergency department from asthma, die from asthma, especially when you factor in gender. Black women have the highest rates of death due to asthma. So these issues are rooted in issues that we've already kind of firmly discussed, but I want to draw attention that there are actions we can take. You talked about talking about the issues, but then also talking about the action. And so when I feel helpless in the moment of like, well, these are a lot of issues and what do we do about it? And there's maps and we can see the facts, but what's our action? Every one of us probably has a different action we can take. We bring something different to the table. For me, it's educating our future physicians to make sure that this is not a missing dot, that the missing connection for the dots they are linking to health. We have this beautiful building that we need to make sure that we are using to its fullest potential and making sure that our education of our future healthcare leaders are complete. But as I say again, in the world of misinformation, education from our most trusted voices is power. I'm sure there's a lot of trusted voices in this room that can be used in different ways. Find out what action you can take. Maybe you've already found it, maybe you're exploring it, so that we can continue to connect the dots and work together as a community to make sure that this is fixed, this is improved. So with that, I appreciate it. If we have time, we'll try to fix the video. If not, we can always send the link to Melba to get out to the group. Thank you.
Great, thank you so much for that. And next we have Dr., and you can introduce Sean when you're done. Okay, sure. I'm sorry, Nadine Barrett. She is at the Wake Forest School of Medicine, and their presentation takes a little bit of a pivot, but it's all tied to the health impacts and of environmental justice and environmental injustices. So thank you so much, Dr.
Excellent. Thank you so much, and thanks for having me. And most certainly, it's always an honor and a pleasure to see if technology is going to work for me today.
Mm-hmm, mm-hmm. I'm trying to see how we get this. I'm supposed to have them all up there together. Where the next one is.
Are they all in there? They're not in
There, yeah, they're all in there together. Let's see here. I hate technology. No, I don't. I mean, I hate it when I don't know. There you are, right. Here.
Excellent. And then it's not projecting up there.
Okay. See.
Maybe it's enable editing. And then we can go to a slideshow. And then we can go from here. There we go.
There we go.
Excellent. Excellent. Thank you so much. I am excited to be here. There's so many things I have been in my mind since we first started in the session with Dr. Pollard, and we can't say thank you enough again for your talk. I just also have to just highlight that I also am a sociologist. I'm a medical sociologist by training, and that is always exciting to me because I always remind people that sociology is not just the undergraduate elective. You actually can have a full career as a sociologist and make a difference, and so just really excited about that. I also am really glad to be able to really think about, as we talk about these things, there were a couple of us that were standing at the coffee station or the tea station trying to get coffee and tea earlier, right after the talk. And we all were kind of standing there like, okay, so now what do? We need to do something. And it's always when you get this incredible message like what we heard this morning that pushes us into, okay, so where do we go from here? How do we actually make a difference, and what does that look like for us? And so I'll just highlight a few things. I'll introduce myself. I'm Senior Associate Dean in the School of Medicine for Community Engagement and Research Access, and I'm also Professor of Social Sciences and Public Policy. And so I'm really, really thrilled, again, about the opportunity to think about what does this mean for us. And one of the things that's huge for me is really thinking about community engagement. Community engagement is really an important piece that sometimes we miss. And yet when we looked at the presentation today, there was plenty of engagement, including when I believe it was middle schoolers that were laying there protesting. So I think one of the things that we have not done a great job of is really engaging our communities in ways of identifying what kind of action can our community members make, regardless of where they are and who they are. There's always spaces for that. And so I love to always refer to my mom and my grandmother. My grandmother, my mom particularly, always made sure that when I was a kid, from about 6 years old until I was about 13, 14 years old, would always take me to nursing homes on the weekend and have me sit with the elderly. And my mom would always say, don't go doing a lot of talking, Nadine, just listen, just listen. She thought I was a talker. I don't know where she got that from. But anyway, side note on that. But definitely always having me listen. And so I would really learn from a very early age that the world does not, one, rotate around me and my own opinions. There's a lot of different perspectives that exist. And it's important to understand them, to know them, and to work together to align to make change. And so when I heard the talk today, it kind of just brought me back to those roots, my family roots of, Nadine, what is it that you need to do and what is it that we need to do to create change? So I lead the Office of Community Engagement and Research Access within the Wake Forest, and one of the key parts of that is really thinking again about how do we, all these data that we've been looking at, how do we translate that to community that is digestible? And they therefore evokes change, right? It's one thing to be able to look at the data and be able to say, okay, this is great, and it's awesome, and it's things that it highlights things that we need to do. But how do we make it digestible? And part of making it digestible is actually engaging the communities and helping to make it digestible. Oftentimes we may kind of say, okay, we want to make it relevant for the community. We go off, we kind of make up something, and then we bring it back and say, here you go, community, take that. What are your thoughts? But the reality is that we need to do something deeper. And all the work I've ever done and continue to do, and some of my colleagues that I've worked with for years in this room, so it's almost like a family reunion for me in this room today as well. But all of us in different ways know the importance of community engagement and community expertise. And so I've been really moving us from talking, not so much, I think it's important to have community voice and perspectives, but when you're sitting at tables where decisions are being made, when we have the community voice, and then you have the MDs, the PhDs, and everyone else at that same table, that voice doesn't just seem to have the same gravitas to me when I think about it. So we're really moving toward using the term as community expertise. Expertise, a word expertise, comes from experience, lived experiences. And so those expertise and lived experiences is the things that I believe really shapes us toward that next level of action toward change. How do we engage communities in a meaningful way as partners at the table, as opposed to just simply hearing their voice and then saying, thank you, appreciate you, we'll get back to you later. So in core to that then is our core pillars, and I won't get into this too much, but again, it's really ACE is what we're referring it to, is again, amplifying community expertise. And I'm going to just spend a few minutes highlighting some of the examples that we've done, both within our work and with the Maya Angelou Research Center for Healthy Communities, healthy communities. I'm looking at you. so I'm like, yeah, we changed the name recently, but again, we're just really excited about the work that we do there. I am also director of community engagement for that center, and you'll hear more about that momentarily with the work that we're doing specifically around the faith work and partnering with the Divinity School. So you'll hear more about that shortly. I just want to highlight a few quick programs and projects that we've done that kind of highlights a framework, if you will, that can help us to start thinking about how do we really evoke change, and how do we do that in a meaningful way in lockstep with our communities instead of to or at our communities. So this is, prior to being at Wake Forest School of Medicine, I was at Duke for 14 years, leading some significant senior leadership work around engagement as well, and really bringing together our communities and our health system and our research. And again, I'm going to shout out Leatrice Martin in the audience over there, which is awesome. And I believe Joyce Page over there as well. Those are my awesome colleagues that we worked together for many years at Duke, and also was a part of the work that I'm about to show as well. So I'm just really moved by the they were here and we're all here together in this space. But this is really about trustworthiness, right? We always talk about how do we build trust in the community, and the reality is how do we become more trustworthy as organizations that provide healthcare and work? When we say trustworthiness, it takes us from thinking about how do we build trust in the community, which means we got to fix something out there, to when you say how to become trustworthy, it means we got to change something in here. And so really making us and thinking about organizations is really moving toward trustworthiness. This is Project Entrust, and this is where, again, we've created a framework to engage communities in systems and organizational change at Duke. Two key things about this work is that we wanted to work together with our communities to create change. And so we identified a survey that we built together with our community partners, and the community partners were very open and honest and raw about what the experiences were and what their thoughts were around how do we become more trustworthy as an institution at Duke. We then did the survey with the community. We identified some key domains and opportunities, again, experiences of racism, discrimination, opportunities to really think about how do we provide better care. But what was really powerful throughout that whole experience is that within 8 weeks, a little over 8 weeks, we had over 6,243 people respond to that survey. And the survey, we entitled it using ChatGPT, because they will give you a great title if you need a title for a survey. This one was so creative and unique. It was called Help Make Duke More Trustworthy. I mean, really creative, just to tell you. And so that's what we named the survey. Very simple. So like, thanks, ChatGPT, we've got it. So we sent that out, and basically we got, again, 6,243. Not only did we get that response, but we also got a response that reflected our community demographics as well. With that, we also, again, engaged our patients, communities, and we engaged our community-based organizations, including our local FQHCs and health systems that have been working with us, to identify how are we as a partner, and what does that mean, and what do we need to do to be different in that space. So as a result of that, I'll actually back up one more time again. Not only did we have 6,000 respondents, but we also had 3,000 open-ended stories that people wrote about their experiences. And sometimes we talk about things in the past and say, this is why people don't engage in research. This is why people don't trust the health system. And that may be very valid, but most of those 3,000 entries were about experiences that they had last week, last month, or last year with them and their family members in the healthcare system. So I think it's always important to note that what happens in the past still bridges and happens in the future. So it's not just historical things. But that allowed us to become more trustworthy. Now Duke is working together with community organizations. We actually had the community interpret the results instead of us as the researchers interpret the results. So we had over, I think it was like 400 or so people that we had, plus we did this with COVID as well, where we had a number of people that came together in town halls. We presented the data, just raw, and then they interpreted what it means, what it looks like, and what the solutions are for it. So again, when we think about how do we take the work that we've been hearing about from my colleagues here on the panel and from Dr. Pollard, these are the ways that we can start moving into action and engaging our communities through that process. The other piece that we've been doing is really about normalizing research, and so the part focused on, again, is ACE, Advancing Community Expertise, or Amplifying Community Expertise, and then also in normalizing research. And in this case, we really created a think tank. So at Wake Forest School of Medicine, just a quick backdrop, we are now the academic arm for Advocate Health. And if Advocate Health is the third largest nonprofit academic health center across the country. So our footprint spreads not just in North Carolina, but in Georgia, South Carolina, Illinois, Wisconsin. So we have a very big footprint in that space. And so the School of Medicine here is actually the academic arm for all of that across the space. And so when I said we need to start doing some engagement. So again, this is just another quick model. Brought together a think tank of all the people that do community engagement across the entire footprint that I just described. We had a think tank through my team and through the office. That think tank actually led to some specific opportunities that the communities and our teams who lead community engagement came up with together. So that means that all those people that were just mentioned across those states all have vice presidents and associate vice presidents that focus on engagement. We also incorporated their partners in this 2-day think tank. So they all came to Charlotte. We had a 2-day think tank. 1 day kind of talking, then second day action. This is another way that where I've just learned what we just talked about about today, we can now bring that to this think tank and think about what is our next steps. The other piece is misinformation. There's a lot of misinformation, and I cannot appreciate you saying that more than ever. We're really starting to talk about misinformation, and part of that is research literacy. Research literacy is important because I think that we have not done a good job as researchers to let people in our communities know how research is relevant to their everyday life, whether we're talking about environmental justice or simply using toothpaste. All of that is from research, right? And so I think it's really important for us to start doing a better job of that. And that will also help to combat some of the misinformation that's out there, and then creating trusted spaces to be able to share that information. And then who do we galvanize toward really speaking to our political leaders, but then also those political leaders, mayors, et cetera, they only get into those positions because they're voted. They're voted into those positions. And so I think it's really important that the more we educate the community, the more they can have the arms and the words and the discussion that they need to have to be able to impact what our elected officials are doing, but also who comes in next in that seat. And so I think those are critically important as well. So I'm going to stop there. This is another just example again of us really driving innovation through trustworthiness, but it's about action, right? It's bringing people together, hearing and figuring out in what different ways do people need to get the information so that they can digest it and then come up with the ideas and the ways toward action, and then working together as teams. And when I mean teams, I'm talking about the community at that table as a partner, a colleague, an expert in their own right toward change. And so I say that, and I'm going to pass it on to my colleague now, Stacy Smallwood, who's going to speak more about the great work we're doing within the Maya Angelou Center with my office and also with the Divinity School. But it's really wanting to shift it and shift from how we typically make decisions, shift in how we typically do communication, and start becoming more trustworthy by engaging our communities in a meaningful way, an authentic way, and truly, truly, truly understanding the expertise that the community brings toward transformation and change and better health for all. Thank you all.
All right, good morning, everyone. It is a pleasure to share this space with you, and I'm very excited to be part of this conversation. My name is Stacy Smallwood. I have the honor of serving as the Executive Director and Principal Investigator for the Faith Compass Center in the Wake Forest University School of Divinity, and I will share a little bit more about what we do and how that ties into the topic at hand in just a moment. But I am just very honored to share space not only with this panel, but Dr. Bullard, so gratefully honored to have you in this space as well, and to see more about how our work intersects. Now, for those of you who may know anything about the Faith Compass Center, as I'll speak more about it in a moment, we do work around HIV and faith communities, which at first glance may not seem like it fits in with the theme of this particular panel, but I promise I'm going to bring it all home and make it all connect in just a second. But just a few words about the Faith Compass Center, and I'm going to try to move expeditiously through this because I really do want us to be in conversation. But the Faith Compass Center is one of 4 coordinating centers across the South as part of the larger Compass Initiative. And our goal is to advance the capacity and organizational resiliency of faith communities to address HIV/AIDS in the U.S. South. And there are a few ways in which we do that. One is through transformative storytelling. In other words, how are we shifting narratives around HIV in order to move away from stigma and move us toward more life-enhancing and life-affirming possibilities? We also do a lot of educational offerings. We also have done a lot of strategic grant making. To date, we have awarded about $4 million to various community-based organizations and faith organizations across the U.S. South in order to support innovative HIV prevention, advocacy, and treatment opportunities, as well as shifting narratives. And so I like to show this slide because this really illustrates what faith in action looks like for us. These are some photos from our 2025 Summer Institute, where this is the second year in which we've taken attendees on a journey about how to re-story, how to tell a different narrative, not one that is based in the in the past or things that we have just taken and assumed, but how do we really think critically about how we show up for each other? How we interpret our own stories to be able to then communicate them to others. And so this ties in very neatly with what Dr. Barrett was just sharing about what it means to do authentic community engagement and provide platforms for people to be able to share their stories. So although I work in the School of Divinity, I'm public health by training, so of course I got to do a little bit of epidemiology. Y'all bear with me, we're going somewhere. But just, we don't talk about HIV in the ways that we used to. As Dean Walker mentioned earlier, we just celebrated World AIDS Day yesterday, and celebrate is an odd kind of word to use for this, but we commemorated World AIDS Day. Well, why is that still important? In the United States, there are still an estimated 1.2 million people who are living with HIV. Of that estimated number, about 1 in 8 are still unaware of their HIV status, right? In 2022, there were approximately 38,000 new HIV diagnoses. Now, let me be very clear. Those are diagnoses, right? Just the people who have gone in to get tested to find out their status. Now, that number has come down. When I first started this work many years ago, we were around 55 to 60,000 new diagnoses per year. So that has come down. There has been progress that has been made. But the problem is that the disparities in HIV still exist. And those disparities follow racial and ethnic lines. So as we see, African Americans comprise about 14% of the US population, but in terms of new diagnoses in 2022, comprised 38% of new diagnoses. This is not a problem that has gone away, just because we have not been talking about it. But we not only see these disparities in terms of race, and we also see them in gender, sexual identity, all the things that we're not allowed to talk about anymore, but we also see them in terms of geography. The South accounts for about 38% of the US population, but we account for about 52% of new HIV diagnoses. So the center of the HIV epidemic domestically is very much entrenched in the very space in which we are residing and taking space right now. So there is clearly a lot of work that needs to be done. And I want to even take it a little bit more granular than this. I will also mention disproportionately high rates of HIV diagnoses, but one of the game changers that has developed over the past 10 or so years is pre-exposure prophylaxis, or PrEP. Right? So we have different kinds of medications that, when taken consistently, can help to reduce the risk of HIV acquisition by more than 90%, in some cases up to 99%. But what we also see is that even though we are in the place of greatest need because of the disproportionate rates of HIV, the South also accounts for the lowest rates of PrEP uptake. So there is much work that continues to need to be done, and we can even, because MAPS have been a theme today, but why do we focus on the South? Because some of the areas that have the greatest HIV diagnosis rates are here in the South. And so what you can see is that this map probably looks very familiar to y'all, because we could overlay just about any type of disparity and it would look exactly like what we're seeing right here. Mm-hmm. So, and it is not just an urban issue. When I used to work in Georgia, so many people thought, oh, well, HIV is just an Atlanta thing. It's just one of those city things. But if you look at the map of Georgia, what you see is that some of the highest rates are in Middle and South Georgia, some of the most rural areas in the state, which also have some of the highest proportions of African American population. So then the question may be, well, how does HIV intersect with environmental health and climate change, right? Those don't necessarily seem like they go together. We don't talk about them in the same conversation. Well, one of the biggest areas in which environmental health impacts HIV is through health delivery systems. We live, as mentioned before, we live in an area that is prone to severe weather, to hurricanes particularly, and as climate change continues, we just saw Hurricane Melissa, which almost doubled in strength over like a day or two, right? 180 miles per hour winds, right? It's been a long time since we've ever seen anything like that. Well, what happens when we have these extreme weather events? People move because they are displaced, and that also decreases their access to healthcare, which for people living with HIV is already distressed because we do not have the level of access that we need in order to really end the epidemic. So if I do not have a stable address, and I typically get my medications mailed to me, where does that go? If I am in the Ryan White HIV/AIDS program and the Ryan White clinics are closed, how do I get access to my medical care? So that climate vulnerability has an intrinsic connection with ability to access healthcare. And that goes for prevention as well as treatment. Another thing, food insecurity and transactional vulnerability. If food access or if food apartheid disrupts my ability to access food, then what kinds of behaviors am I going to engage in order to get my basic need for food met? Another thing that is a connection is the increased risk of opportunistic infections due to climate change. As the planet warms, it contributes to a proliferation of pathogens. HIV is a condition that impacts the immune system. And so most people who are living with HIV, when we talk about people who may, we don't talk about people dying from HIV, they die from an opportunistic infection, perhaps. Mm-hmm. Well, if there is a proliferation of pathogens and people are immunocompromised, then that's a connection as well. And as already been previously mentioned, the increased mental and emotional distress that comes along with the compounding of different issues in people's lives. So where does the faith response come in here? One of the things that we have to do is reduce stigma. And we focus on HIV, but there's stigma associated with all kinds of health conditions that needs to be addressed and it needs to be combated. How do we do that? For one, what are we doing to proliferate health and wellness ministries in order to help reduce stigma? We know that a lot of HIV stigma is also intersecting with sexism, with homophobia, and with racism. How are we combating that, not just in our communities, but also for those of us who may be part of a faith community, how are we combating that from our sacred desks, from our pulpits? Promoting health and wellness across the spectrum and shifting the lens when it comes to theological education. What would it mean for us to really think about not doing any harm from our sacred desks? What would it mean if, for example, we looked at Mark chapter 5 and we talk about the woman with the issue of blood, right? So we refer to her in terms of her condition as opposed to looking at her humanity. What would it mean for us to actually look at that passage from a different theological perspective to see not only that when Jesus speaks to her and recognizes that the power flowed from him and he said, "Who touched me?" He turns to her and says, "Daughter," right? So recognizing the community that is present there and says, "Your faith has made you well." So it is the power of her faith that contributed to our healing. What would it look like from an empowerment perspective for us to shift the lens of how we address certain kinds of issues? So where do we need to go from here? One, we need to embrace the synergy between theological education, science, and health. We need to intentionally engage communities through equitable and authentic community academic partnerships, not having a community advisory board just for the sake of saying that we have a CAB, but rather that they are active participants and co-researchers and co-creators of knowledge production that then is able to be transmitted and shared equitably through community. Expanding the scope of innovative research on faith and health and wellness. We do not have very good measures. For those of us who may be quantitatively minded, it is difficult to quantify the relationship between faith and health. So quantitative measures may not be the most appropriate way for us to do that. Or if we do, we need to develop new measures. I worked with a colleague from Rowan University on the development of a new quantitative measure around religious and sexual identity integration. So not just focusing on the homophobia that sexual minoritized communities face, but how do they reconcile their religious identity and their sexual identity? What are the points of strength and resilience that come out of that, right? And then emphasizing the role of intersectionality in the concept of health in action. And as we are talking about that need for innovative research that contributes to action through authentic community engagement, this is hot off the press. Y'all are getting some really good news right here. So we want you to take it out here. But one of the things that Dr. Barrett and I have the pleasure to be a part of is a new research collaborative between the School of Divinity and the School of Medicine at Wake Forest University. And it is the FIRE Collaborative. And FIRE, we got really creative with acronyms, but it stands for Faith-Inspired Healthy Communities Research Collaborative, where faith meets evidence to strengthen community health. So the purpose of FIRE, and I'm not gonna read all this, but basically, we recognize that for us to do the work that needs to be done, we need to not only open our minds and get out of the silos in which we typically operate, and really think creatively to support transdisciplinary research that is rooted in faith-based values that can address issues in faith communities and beyond. And so what we want to do now is actually invite you to share in that work with us, to become colleagues and thought partners and subject matter experts with us. So we have a short survey that we would like for you to complete. So if you would, please scan that QR code. It will take you to the survey because we really need all of our input about how we can, again, move out of our silos and work collaboratively and creatively in order to address the issues at the intersection of faith, health, and the environment. Thank you.
Thank you so much for that. And this panel proves what I always say, that every story is an environmental story. Every story is a climate story. So we have these connections, and that's why it's so important for us to have community engagement and do storytelling to impact and to inform our community. So we started a little bit late, so I'm just going, if there are any questions, I'm going to just take one or two questions because we're going to lunch and we don't want to be at the tail end of the lunch line. So do we have any questions for our panel or comments? Anyone?
Okay, good morning, everyone, and just thank you for this very insightful presentation. My name is Keon Lewis, and I have the privilege of working for Mecklenburg County Public Health in the community health engagement aspect, and especially as being a coordinator for the community health assessment. So Dr. Smallwood, Dr. Barrett, I will be in touch with you after this because I love your insights and your ideas on this, but just wanted to kind of get some more insights from you on the vision for FIRE, because I've been in spaces where we talked about what enhanced community engagement looks like and where that balance and that intersectionality comes with being more engaged with the faith-based community and finding that balance. And to be honest with you, this is the first time I've seen a collaborative like this that's been intentionally created from a med school standpoint that's looking at this. And I'm curious to see if this is going to help drive future research opportunities, curriculum, things of that nature. So we'd love to hear more about your vision in creating this. And I just love the acronym for FIRE.
Hi, how you doing? Excuse me, Dr. Adam, right? Your name? Yeah. Oh, I'm sorry. I am very bad with names. Are you aware of Latinos in the South?
As an organization?
Yeah, it is. I was part of like a focus group they did, and they tried to work different strategies promoting PrEP. It was very, they had a lot of research in the Hispanic community. It was very good. They have a lot of information and they were doing a strategy in different community clinics. So I suggest you talk to them, or I can give you the information on the person who can talk to.
No, that would be very helpful. Thank you. And one of the, I didn't really talk about it in the presentation, but we have part of our funded partners and the communities that we work with throughout the South are also Latino communities. I'm thinking back to over the summer to one of our funded partners out of the greater Orlando area who gave us a lot of insight around the intersection of faith and health as it pertains to PrEP, and how there are opportunities for us through the Catholic Church to be able to promote PrEP as well. And so we're always looking for new information, new partners. And so any information that you can provide would be most helpful. Thank you. Yeah.
And also, just to be specific too, the example for the fire was the HIV piece that was highlighted around Compass, but faith, the fire is disease agnostic. So it's all diseases. So we're focusing on HIV, diabetes, hypertension, you name it. So really just ensuring that we recognize that as well. So it's kind of really, and rural communities as well as urban. So really wanting to be as broad as possible. So as you answer that, also answer it in the context of areas that you think, if you think there's something that we should be focusing on that we're not, highlight that. You highlighted misinformation, bring out misinformation in health and understanding healthcare. So whatever that looks like, bring that out, because that's where we want to get your input. And it's also going to inform depth as well, the digital engagement platform. I'm going to sneak and feed 2 birds with 1 seed. Notice we're not killing the birds. We're feeding them. I'm going to feed 2 birds with 1 seed instead of kill the birds. Okay, so there you go.
Yeah, you just answered the other question because I didn't understand the connection with the other aspects to the faith community. Thank you.
Great. Thank you all for coming. Let's give a hand to our wonderful panelists. So thank you for your participation, and I think it's lunchtime.